Welcome to the Electra-Med Edge, where we explore the science, technology, and innovations advancing human performance and patient care through precision measurement. I'm Andy, Clinical Sales Manager at Electra-Med, and I'm excited to have you join us as we launch this new series. Electra-Med is proud to be a service-disabled, veteran-owned small business founded in 1975 as a biomedical service organization. Nearly 5 decades later, our mission remains the same: to deliver not only cutting-edge equipment and supplies, but also the support of the sale, meaning we're here for our customers long after installation and training. Today, Electra-Med provides full-service solutions across neurology, cardiology, physical medicine and rehabilitation, sleep diagnostics, respiratory care, and U.S. government contracts, serving clinicians, researchers, academics, and performance professionals nationwide. Through Electra-Med Edge, we'll bring you conversations with experts, insights into emerging technologies, and real-world applications from across these fields, all aimed at advancing human performance and clinical precision. Let's get started. Everybody, my name is Andy. I'm the Clinical Sales Manager here with Electra-Med. Today we have an excellent guest. His name is Alex. He is with Frontline Mobile Health, but I'm going to do an injustice of not introducing him the best way. So Alex, go ahead, introduce yourself for us and maybe a little bit of background of what you do with Frontline Mobile Health, and we can go from there.
Yeah, absolutely. Thanks for having me, Andy. My name's Alex, like Andy said. I've been using CPET for almost 13 years now in a clinical context. So before Frontline Mobile Health, I worked for a healthcare system using CPET as kind of like a frontline measurement for kind of risk stratification for patients. We know which direction they needed to go, whether it was specialty care or primary care. And then through the course of doing that, I met some of the guys at Frontline Mobile Health who wanted to transition from the treadmill testing into something a little bit more comprehensive using CPET. So that being said, at Frontline Mobile Health, we do all of the fire and police annual medical evaluations. So every year we get to see them. So having the CPET data trended year to year provides enormous diagnostic utility for those guys, as you can imagine.
Sure.
So that's what I do at Frontline Mobile Health, is pretty much manage our CPET program, using all the machines, the data, and leveraging all of that in a preventative capacity.
Sure. Well, that's a beautiful thing about CPET testing, right? It's not just another test. I think it's, you can argue with me, but I think it's the only tool that really helps to integrate all the above: cardiovascular, pulmonary, metabolic systems really simultaneously.
Yeah, it's the most data-rich in a diagnostic test that, I mean, we can perform for these guys just with one test alone. I mean, you get much greater visibility of just overall cardiopulmonary function, cardiovascular health, tons of fitness information. So I think that's really where CPET shines, is you're kind of getting the best of both worlds. You're getting all of the fitness data, which most people are interested in, as well as the clinical data and how you need to manage that patient.
Absolutely. Yeah. So it stops guessing as to like why someone may be limited and really brings it into actually quantifying it. Right. So that's especially, when you're using, like I said, I know we talked last week, but like the Loda Scorable bikes really geared for this type of testing. But as we move in, so your background is exercise physiology, correct?
Oh, yeah.
Yeah. So why do you think it matters for exercise physiologists to really dive deeper into CPET testing, even as you mentioned earlier, over like treadmill testing, VO2 max testing?
Okay, so you're speaking more deeper level than just kind of like the fitness measurements that we all know, VO2 max, power, and things.
Yeah, let's dive a little deeper into that. Yeah.
Yeah, so what's driving being able to do those things? Like, how were you able to achieve that VO2 max or that level of power? There's a physiological basis for doing the work. So if you want to know, first of all, if their function is normal, you need to understand what's normal physiologically: heart rate response, O2 pulse, and just kind of the ventilatory equivalence across the exercise session. right? So how efficient are they with their gas exchange? Is there a limitation present? Could they be performing better? Is there a pulmonary limitation, cardiovascular limitation? And if there is, what are you going to do about it? How bad is it? And
Sure. What do you, if you can maybe go into a little bit more detail? So you work with a very unique population, right? Fire, EMS, police. So ultimately, they fall under that tactical category that we're kind of there's a big push into now. How would you say maybe doing this testing for as long as you have, you've seen differences, or maybe there's some similarities to a clinical population?
I mean, you're going to have a range of fitness levels and also medical conditions in I mean, most are higher performing than your general population. So sometimes your standard prediction equations don't often fit these guys the best. However, there's also a relatively normal kind of section of the public safety sector that is very in line with just your general population, their status, their fitness level, and things like that. So it's not like they're all just, head and shoulders above what those normal clinical values are. So they're still very applicable, but you do have some cases where they're just head and shoulders above.
So what gets you excited when you're doing this type of testing and this work within this population?
I mean, it's always with a new department. Those are always the best because they just have no idea what they're about to get into. Usually they've done the treadmill test.
Okay.
Right. So similar, but different. They kind of know what's about to happen, stress tests, like they're familiar with that, but they just have no idea the amount of, to your point, objective data about themselves that they're going to get. So usually they just get, checking the box. They do their 85% of their heart rate on the treadmill. They stop, no ST depression. They're good to go. But whenever you're able to get them off the bike and show them, this is exactly what you did during the test. This was your substrate utilization. That's one of, I would say we spend more time talking about the substrate utilization during exercise than anything else with patients afterwards.
Interesting. Yeah.
So that's always fun. And then the year two those are really my favorite because year one is kind of shock and awe. They don't know what they don't know. And so you definitely give them a lot of information that they can action on now, as opposed to the guesswork. Like now we know exactly where you're at. We've got a glide path to improvement. Do these things over the next year and we'll see how things change. And so year two is the fun one.
Sure. What about, and I know you've been doing this for quite a while. What about like years 3, 4, 5? Are you seeing anything like that? Guys are now trying, or women or two are trying to maybe outdo themselves. They're locking in more into their health, their fitness. What are you seeing in those years?
Yeah, they start to accept the the finer tuning or optimization rather of the program. So if there's not any major concerns, then we're just constantly splitting hairs year to year and where we can actually stabilize or make improvements. We had a really good case study at the end of the year last year where we had seen this guy for 5 years.
Oh, wow. Okay.
Yeah. So we had a lot of trending data to kind of see what was going on. And for the face level, you would think, oh, this guy's good to go. He does very well on the bike. His VO2 is high. But there was a serial trend over the last kind of year and a half, a downward trend that was kind of alarming. And so we referred this guy out for imaging, and his CAC score came back over 1,000.
Oh, wow.
Yeah, normal labs, that's what I'm saying. On its face, there wasn't really anything that was just really hair on fire, but there was definitely a concern that you were here and there's just been this downward trend that isn't in alignment with, how much you exercise, the things that you're doing. So using CPET, we were able to just see that very clearly and get in front of that before this guy potentially, could have had a massive event.
Sure. And obviously the cardiovascular disease and heart issues is prevalent in that tactical population, right? Fire, police, EMS. And getting ahead of that. That's a huge component that you guys can recognize.
Yeah, it's still the thing that's killing them the most, sadly. I mean, it's interesting because we know so much about cardiovascular disease, preventing it, managing it. I mean, that is just it's the patient compliant component that is still the most difficult.
Yeah. No, it's funny. And as we talked a little bit last week, I want to kind of dive into, like, we talk about getting into the continuum of care, right? So you have a baseline CPET, as you've mentioned. Now you're potentially doing a targeted intervention, repeat CPET. Where do you think maybe some of the disconnect comes about retention or at-home management, things like that?
So we always lose a little bit of, and a best way to put it is control over, you know, where the patient goes and what they get once we have to refer them out. So it's always the gap between the CPET and the next provider, whether it's primary care or specialty care, and how well or familiar they are with CPET in general. Shockingly, there's still a ton of cardiologists that aren't familiar with CPET.
Right. And, it's funny because we talked about that again last week, and I'm going to bring some of our, guests back into it. So we had a really good conversation last week when I was actually at your facility down in Texas about the amount of cardiologists that maybe don't recognize how CPET is a beneficial tool and adding it into even an annual physical assessment, right? And so kind of jumping back into the present day here, how else would you explain that to folks of, like, why do you think cardiologists aren't familiar with the CPET testing?
So they rely on imaging and of imaging. And that definitely tells you how the house is built,
Right.
but not how it's functioning. So if they don't use it, they don't know what they don't know. But in tandem, CPET and imaging provide you just about everything you could ever want to know about that individual's cardiovascular status.
Absolutely.
So you can see what's there and how big of an impact functionally to that patient is it. And if you provide some kind of therapeutic intervention, whether it's, stenting, medication therapy, how beneficial is it to that patient? Imaging's not necessarily going to always show you that, but CPET absolutely will show you, the benefits of whatever intervention that you've taken.
Sure. Obviously, another little continuation of our conversation last week. You're so passionate about CPET, which I love it. And, I've been told, more about CPET than others have already forgotten, right? Or no, I'm sorry. You've forgotten more about CPET than some will ever learn. So what else gets you, like, really excited about CPET? And maybe as we start to see how this could be implemented into the continuation of care.
And it's seeing it being utilized more, and the evolution of the technology and the precision in which it's able to provide, and providing another career pathway for ex-phys. So that's one of the things that gets me pretty excited as well, because if you're an ex-phys, you probably know you're either going to go to cardiac rehab or you're going to get into physical therapy. Those are your two kind of career pathways at the moment. But CPET's kind of opening up, that advanced physiology minded career path for individuals. And
Absolutely. And again, there's this continuing to, I say, but let me back this up. What do you think maybe some of the bigger barriers for exercise physiologists who aren't as familiar? Yes, they know CPET testing, but they think about it more just, oh, that's a straight clinical space. What do you think some barriers are preventing those folks from getting into a general practice or even a environment like you?
Well, it's going to rely on the clinician. So you can't use me as a good example because we're private. So
Sure.
we have the luxury of kind of using whatever testing equipment, that we think is the best for what we're doing. But it's going to rely on clinics, healthcare systems at the top level adopting CPET into their environment. And then once it is, it's going to be no different than what occurred out at the old healthcare system I worked at. Is okay, well, we want this information, but who knows how to do it? And who knows how to, one, run the test, understand the data, because I think the barrier to entry a lot of times is, well, that's just too complicated. Like, and for just too much, too much data to sift through on the back end. I don't have time to sit there and do all of the post-test analysis.
Sure.
The test is too complicated to run. And the barrier to entry is just a knowledge gap. And
Gotcha. Now, do you see, I don't know how much you like work with students or engage with students at all. Do you see the upcoming trend, like moving into that direction or gear towards more preventative health at all?
So the most academia is still currently focused on just the fitness component to VO2 max. I've had a lot of interns and students that have been exposed to gas exchange testing, right? They're very familiar with all of the CPET variables, but they just have no idea of the clinical utility that it can be used for. So
Sure.
I wish that most universities would start to at least add that into their, kind of ex-phys labs, having more classes that take it beyond just the general fitness component. Because if they're going to be doing CPET outside or after they graduate in a clinic, they're going to have a huge, there's a lot to learn beyond what they learned in school. And so a huge component to when we bring staff on is great. You've seen this before, you kind of know what's going on. Now we've got to educate you on that clinical component because it's just not there.
Sure. That makes sense. Obviously, I think academics or in academia, they're trying to juggle time constraints and fitting so much into a 16-week semester or whatever it may be. But I think you really just helped to lay out a really nice aspect for how they can position themselves to leverage CPET or getting more involved with it, not only for the clinical impact, but also professional growth. So appreciate you sharing that component there.
Yeah.
That's great.
And our time is coming. Like, there's a groundswell and utility of ex-phys in a clinical setting. There's at least acknowledgement and recognition of the benefit that they provide, to a clinical team. And
so with that said, your dream aspiration here for exercise physiologists, like maybe build on that for us. Like, where would you love to see this go? You mentioned groundswell, and I agree with you, right? That it's about to pop. But what if you had the grand aspiration? What would you love to see happen?
And in every, so not in necessarily smaller clinics themselves, but in every healthcare system, there needs to be a group of ex-phys that have broad utility across cardiac rehab, working in the cardiologist kind of lab or, offsite clinic. They're even very helpful in the PT setting. Like they could be used in many different areas of healthcare, even in PACU, right? Just making rounds on the floor with patients and kind of discussing post-op exercise and things like that, to speed up recovery. So I think they could go in any area of a healthcare system and provide a benefit. And
I agree with you because exercise science, exercise physiology, kinesiology, I know each program has a little different title, but I think it lays such a strong foundation for exercise physiologists as a whole. And then they can navigate it through experience, through, time in clinics or time in private, wherever it may be, to elevate that even more. So that's a fun aspect. Well, great. So I kind of, a couple more talking points here as we get through this. Going back a little bit to your just general experience and overall talking about how you utilize CPET a little bit more, what else do you guys really dive into? And I don't necessarily mean, your population, but your just experience as CPET adding like functional capacity or either early detections of decline before disease manifests, like you mentioned earlier.
Yeah, I mean, you're asking more about our program specifically, or?
Well, your program, your work in general, from prior positions up till now, just really, like I said, I've heard you're the guru of CPET, so just want to highlight that for everybody.
Yeah, so we've expanded into kind of doing a continuum of care for some departments that's we've seen a lot of benefit from the retest kind of usage of CPET. So there are some departments that use us for their, annual tests. And if that individual has some things that we want to work on or their fitness is below, the department standard, and they're trying to optimize them medically or, exercise therapy, and then we'll retest them in 60 days. And so from that retest, we kind of know which direction we need to go, if we need to escalate our care or continue with the aggressive exercise therapy. And
Gotcha. No, that's great. So, we talk about that, and you talk about some data mixed in here too. Is one thing we look at the trends, right? We have a resistance over a ramp protocol, and we're trying to match heart rate versus stroke volume, cardiac, like how all that's interplaying. Maybe you could dive a little bit deeper into us for how do you utilize those metrics? I know that's a little sophomoric, but also mixing in the substrate utilization, as we mentioned earlier.
yes, so more in-depth test variables.
Yeah.
Yes, so the ramp is usually people have run all kinds of different protocols, right? Treadmill, like anybody that's watching this, surely you've run tons of different exercise testing protocols. I have not run anything other than ramp protocols in the last decade. So the ramp protocol has just been my bread and butter for just the linear workload. And from that linear workload, now we've got a steady line, steady slope that we can start to overlay variables on and see different trends, right? What we usually are looking for, most of these guys are generally healthy.
Mhm.
And
So
about 3 to 4 minutes into the test, the ramp is enough to start seeing, some of the body systems upregulating, ventilation, heart rate, some of those things. So since that workload is just constantly increasing at the same rate, some of those variables should just maintain that initial trend all the way up to their peak. When they don't, we want to know why. So if heart rate out of nowhere, in late exercise begins to just increase off of that, baseline slope that it was on, and for the why is heart rate having to speed up? What is it compensating for? What is preventing, blood flow or circulation from getting out to the working muscle, which is causing heart rate to speed up and accelerate? So those are often the most common findings we see is heart rate acceleration, O2 pulse flattening, which O2 pulse, as you know, heart rate, uh, it's the amount of oxygen extracted per heart rate.
Mhm.
So it gives you good insight into stroke volume. So you can kind of see some of those inefficiencies. It's subclinical disease in nature, but it is something that we want to find and watch over the years, which going back to that 5 years case study we had on that individual, you could see progressive worsening in that heart rate response, it having to accelerate more and earlier in exercise to kind of compensate for that flow limitation that he was experiencing. So yeah, the ramp protocol is just the gold standard for me. It just provides such a nice linear workload that allows you to really lean on what you're seeing in the patient data in the gas exchange, because sometimes it can be very dynamic how the patient's breathing, but at least your workload was nice and linear. What you see, in the patient data gives you a little bit more precision than a step protocol or some of the other ones.
No, absolutely, absolutely. So, and when you talk about substrate utilization, and obviously because these guys have a very dynamic when they're on a job, right? So
Mhm.
they go from sedentary right through ATP PCR, right through anaerobic, and now they're in a combination of anaerobic and aerobic fitness, right? Because they're either lifting heavy weights quick or heavy equipment, but there could be on a job for an hour or 2 hours or whatever it may be. So when you talk about that, do you relate it back to job demands at all?
Oh yeah. Yeah. So for these guys, it's interesting. They work in reverse order to your point.
Oh, okay.
Right. So our test, the CPET, it starts super easy, progressively gets more difficult. When they go out on a call, they jump off the truck. They're already, starting out working really, really intensely and using, a lot of that expensive energy, so to speak, the PCR system. So fatigue is coming. It's
Sure.
it's piling up. So they almost work in intervals, starting, right out the gate at a high intensity. They make their first hit, kind of figure out what they need to be doing, where they need to be going, recover a little bit, and then go on those little 3-4 minute bursts, whatever the job task is. And they often don't realize, and a lot of them train in the higher intensities because that's where they spend a lot of time. They don't understand how important that recovery component is from that lower intensity, from that, that oxidative system. So a lot of them just don't do a lot of the low and slow, cardiovascular exercise because they don't really see the benefit of it. Like, well, I'm never going to be doing that in a fire. So why is it so important? So being able to show them on the test, hey, right here, like at this intensity is when you start to drift off back. And right here is when you start to produce lactate. So from this point forward, you're kind of on the pain train and fatigue will overwhelm you. The question is how long and how early do you hit that point? So being able to show them objectively themselves, like, hey, this is where these things occur for you. Specific heart rate ranges, workloads, watts. It gives them the ability to make adjustments to their training, add certain things into their training. A lot of them, like I said, are already doing the high intensity, so it's adding in some of that more zone 2 exercise, if you will.
Sure.
And they notice it. They'll come back the next year like, oh yeah, like I added it in. It's boring. I don't always like doing it, but I'm feeling better. Like I'm recovering faster. And definitely notice an increase just in their work performance overall.
Gotcha. Yeah. So do you do lactate testing during the CPET as well? No. The only reason I ask is I think it's an interesting graph to see, like, hey, if you're mixing in some of this low and slow, are you able to push that lactate inflection point to the right a little bit more? And
absolutely. And oh yeah, absolutely. You can absolutely push it to the right through exercise adaptations. That's the key. We tell these guys, like, you can move any of these thresholds, like they're all malleable. It's just how much it will only move with a stimulus. So you adapt to a stimulus. How often and how willing are you to provide the stimulus to make that happen?
Absolutely. But again, it's all coming from the great data that you collect and all of your time that you have spent analyzing it, poring over it, and being able to make sense of this, the data telling the story that you can then tell those guys, whether it be fire, police, EMS, I guess even in a general clinical population too, like, hey, this is where you're at. Maybe somebody coming out of a heart transplant might be in a bit of an exaggeration, but you see where I'm kind of going with that.
Yeah, so when I was back in a clinical setting, we wouldn't always speak about it this way in terms of like, improving their performance. What I would use it more in that regard is identifying the ischemic threshold for an individual.
Oh, sure.
And then, pretty much guiding that patient. This is where we know this is occurring. So plus minus 10 beats of whatever that heart rate is that occurs is your sweet spot. We know going beyond it is not going to be that beneficial because we can kind of detect the ischemia on CPET. And so exercise up to this point, we know it's safe and don't go too much beyond it. So that was a lot of the utility of, the exercise prescription from CPET in a clinical patient is, you can use it to keep them safe, but also kind of try to get the maximum benefit from the exercise sessions that they're doing, try to force efficiency through that stimulus again. If you target where the heart, is vulnerable, it will likely try to improve upon itself. So keeping them safe while also reaping the maximum benefit out of every exercise session.
No, 100%. And I guess even then, that still becomes part of that functional capacity, right? Whether it just be even like routine health or activities of daily living, or if you're getting geared up because you got a call coming in that you got to be ready to go for. So,
Absolutely.
great. Well, as we kind of start to land this plane a little bit, and we touched on it a little bit earlier, but where do you maybe see the future direction of CPET going?
It's going to be just it'll be one of the vital signs. So you go in for your annual checkup and it's just routinely a component of that. That's when you've landed, is whenever that is, just the norm. And there are a lot of people that already kind of have that mindset, like it's just a vital sign, like, blood pressure and everything else. But that would be, and hopefully, the direction that it is going is that it's got broad utility. It should be in every healthcare system, and it should just be an annual marker that every clinician should want on their patients at least once a year.
Sure.
I mean, any increase, as you know, in VO2 is a significant reduction in all-cause morbidity and mortality. That was a paper Mayo put out last year. Even with comorbidities, having a higher VO2 definitely softens the blow of any, disease that may be present. So it's the easiest way to extend life by having a high aerobic capacity, regardless of what disease or comorbidities you may have.
Sure. And that's again getting all into preventative medicine, shifting from disease treatment, right, to more of a physiological optimization.
Less reactive and more proactive.
Yes, I love it. Right. And, again, as you've said time and time again, that the big message is CPET can be used as a early warning system, more of an intervention trigger, if you will, but then moving that into more of a personalized exercise prescription that has just so much more data behind it because you're bringing in so much more data.
And absolutely. I mean, even just something as simple as a medication swap. And
Sure. I had not thought about that, but right, absolutely, right. So
like we're gonna try a different blood pressure medicine, or start a beta blocker. What is that gonna do, to how your cardiovascular function, and for that.
absolutely. So any other work that you're doing right now, whether it be maybe trying to publish some papers or future CPET testing that you're trying to work on, maybe you can share some other your future goals or aspirations.
Yeah, so we have Mike Connor and myself and a bunch of others have been slowly pushing out more and more papers over the last couple of years. And the target currently is helping to guide policy in the fire service at a national
Oh, interesting.
level.
Okay.
So for those that aren't aware, NFPA 1580 is kind of like the national guideline, kind of gives us criteria for medical evaluations, fitness for duty, and things like that. So using a robust amount of CPET data, which we've got quite a few in our database now.
Yeah.
So leveraging all of that, we know what pretty much, most of the fire service looks like. We're in a bunch of different states now. We've got tens of thousands of tests. So how can we leverage that data to start pushing policy at a national level that's more specific and more beneficial to the fire service directly?
Sure. And actually, one question I just had, so you talk about it at a national level, right? And I know you work I shouldn't be assumptive, but mainly with career firefighters, right? And city-based firefighters and everything. But how do you think this can maybe extrapolate into maybe like the volunteer rural communities?
Yeah, so we do a lot of new hires for their
Okay.
initial medical evaluation, and we do a lot of volunteers if the department, decides to. That's really the main thing is we'll test whoever the department wants to. And a lot of times they won't do the volunteers or the part-time guys, they'll just do the career guys.
Gotcha.
So that's just a decision that the individual department themselves make. Should they do the volunteers and the part-times? Absolutely. They go out the same fires as the career guys do.
Right. Yeah, and I know you said you just mentioned you have tens of thousands of tests. Have you seen any differences, or maybe you've looked at this, but any differences between like career firefighters versus like the volunteer or part-time guys, like in terms of physical capacity, training mindsets, anything like that?
Shooting from the hip, like it's something that we are interested in. We haven't really aggregated all of the data. Small differences, but not always as glaringly obvious as you might think. What is interesting is, and I've noticed the difference in the departments that have a mandated policy and a minimum standard
Okay.
versus the ones that don't.
Could you explain that just a little bit more?
Yeah, because if you're not checking or testing, well, then you don't know and you don't necessarily care. So if there's no policy or minimum standard to meet, then there's really no incentive or checks and balances for those guys to maintain a minimum standard. There's not going to be any punitive action or anything that happens to them. Whereas the departments who do have a mandated policy, they know they have to pass a certain level. So
Right.
they're going to be doing something on a regular basis to at least meet that minimum standard.
Got it. No, it don't make sense, right? Yeah, if you don't check, you don't know, as you just alluded to. So good. Well, great. Well, like I said, as we're really starting to wrap up here, one last one I would like to ask our guests: what bit of advice would you give aspiring ex-phys students, early career professionals that really want to, again, take our profession to the next level?
And to get Wasserman's clinical exercise testing, that is your exercise physiology Bible outside of what you learned in academia. I mean, that is just going to be the totality of everything that you need to know. And you'll be learning as you go. So you'll have the contextual foundation knowledge base, to know what you need to know at the onset. And then there's so much to learn as you go because every test is different. Patterns, you see all kinds of different patterns of responses that are indicative of different underlying pathology. Those are kind of like the intangibles that you can't always teach from a book, but you're going to learn rapidly once you do start using CPET and seeing it in clinical practice.
Awesome. No, that's great. So, and then I guess if they were to find you anywhere, could they get in touch with you at all?
And yeah, I mean, we're always kind of having people come shadow, kind of see CPET kind of in this setting and how it can be used and how it's slightly different from the fitness application. We do take interns sometimes, and we're always looking for new staff. So those that have the passion for, exercise physiology at a deep level, we are definitely an avenue for them to put that to use.
Awesome. Well, good. Well, if it's okay, we can maybe put a contact for you in the show notes afterwards.
Yeah. Yeah, absolutely.
Awesome. Well, Alex, thank you so much for your time. I learned a lot more about CPET. This has been fantastic, and how it's utilized in really a niche population, but as well as other just outside of your group as well. So
yeah, absolutely. Happy to discuss with you, Andy. Thanks for having me.
Absolutely.
Thanks again for tuning into the Electra-Med Edge, where innovation meets precision in human performance and clinical care. To learn more about Electra-Med's full range of medical equipment and supplies, spanning neurology, cardiology, physical medicine and rehabilitation, sleep diagnostics, and respiratory care, visit us at electramed.com. Also, check us out on LinkedIn and Instagram at simply @Electra-Med. Be sure to follow, subscribe,
and share this episode to stay on the cutting edge of healthcare technology. Thanks again for joining us, and we'll see you on the next one.